make more testosterone, which is really critical. We don't want to give testosterone from the outside because that shuts down a man's sperm production. We want to help the body to make more testosterone itself. We also look at that balance between male hormones, testosterones, and female hormones or estrogens, because that helps to determine whether we'd use a drug like an anastrozole or a Arimidex, which blocks that conversion of testosterone to female hormones. If there's too much testosterone going to female hormones, we use that medication to block it. And if there's just a problem with low production, then we'll go ahead and give something like clomiphene to stimulate the body to make more testosterone overall. There's a number of other tests that can be used to evaluate a man, but we don't use these for every man, and in fact, it's relatively rare that we use them. So we can do anti-sperm antibody tests, but we don't routinely do that. We'll do it only if we think that a blockage may be present. We'll do a culture, but only if we believe there's evidence for an infection. We'll do ultrasounds, but again, primarily when there's a question of what is going on in terms of the size of the veins or something within the testicle, which ultrasound gives us a lot of information on. And the sperm DNA tests are not routinely required for every patient because they don't always change what you're going to do. But in some cases, those will give us clues about why treatments failed in the past, and we may then use them and help it to direct our treatments for the future. These include what are called DNA fragmentation tests. They look at what proportion of the genetic material in the sperm is damaged or broken. They're called SCSA or tunnel tests. And they're also tests, as Dr. Davis talked about, for aneuploidy, to look at the number of chromosomes that are present. The FISH test is one that he outlined. Results of that evaluation together, the history, the physical exam, the blood tests, semen analysis, then has to be taken into account with female status to look for an obvious cause and whether we're going to go towards a specific treatment or whether assisted reproduction alone is to be used. I'm going to talk a little bit about non-specific therapies as well. So there was one study that came out last year that looked at all of the tests, all of the treatments that had been provided as what are called antioxidants. We usually refer to them as vitamins or minerals, and whether they help with achieving a pregnancy. It was primarily studies that were done for couples going through IVF, and what they reported is that these antioxidant treatments may have some value. Antioxidants, the vitamins or minerals, are used because the effects of oxygen can damage sperm, and they damage it through what's called free radicals. And it's possible that such a treatment may increase pregnancy rates. Unfortunately, the antioxidants that were used in all of those studies together only resulted in about 20 pregnancies, and it used a variety of different medications. So it's not clear which of these really is best or even what dose to use. If you're going to use them, you could use vitamin C, you could use coenzyme Q10, or small amounts of vitamin E, although the type of vitamin E that you use may be important. You can use zinc, and you may use selenium to provide some benefits as well. Unfortunately, even all of these studies taken together don't provide good information on whether these vitamins and minerals will help for a pregnancy to occur and what vitamins or minerals specifically you should take. Genetic tests, we look at all of the chromosomes as what's called a karyotype test, and we also look very detailed way at the Y chromosome to see if any small areas are present, at least in those men who have the lowest levels of sperm production. The genetic tests are done because they can give us a diagnosis. They can tell us why low sperm production is present. Sometimes they'll tell us which men can be treated and which can't. It determines prognosis. It tells us whether some of those pre-implantation tests Dr. Davis talked about need to be done during IVF. And in some couples, it will change the approach to treatment. Instead of going forward with a biopsy, we may say, let's wait a little bit. Our chance of success is low. Often for some couples, it also provides psychological relief, even though we as doctors know that most of the causes of infertility are not something that patients or couples did to themselves, not something they can affect. It's something they were born with. Many people blame themselves in one way or another for the fertility condition that they have, and it's almost never their fault. For those men who have zero sperm in the ejaculate, sperm production is so low that no sperm come out, knowing whether there's a Klinefelter syndrome present or specific Y chromosome deletions are present tells us a lot and helps us to guide that couple in terms of the success rate in treatment and what sort of treatment should or needs to be used in the future. For those men who have no sperm coming out of the body, that can be because of a blockage. So we'll do testing to determine if there's a blockage or if it's just low production. And in some cases, we'll do a biopsy to sort that out. If the patient is blocked, then obviously we want to fix the blockage if that's possible to allow natural pregnancy. If not, retrieving sperm can be done, and that's easy if there's a blockage and normal sperm production. It can be very difficult if there's very low production. I mentioned briefly this condition of non-obstructive azoospermia, where sperm production is extremely low, also referred to as testicular failure. Unfortunately, although as we used to refer to men with this condition as being sterile up to 15 years ago, that's no longer true. But treatment is involved and does require sperm retrieval surgery with IVF and ICSI together. A biopsy is possible to retrieve sperm, but actually we found this microtessi or microsurgical approach is much more effective. And basically what's done during this surgery, as shown on this slide, is for me to look through an operating microscope and examine many, many areas of the testicle without damaging or removing anything, and try to find the areas that are shown in this blue here, where the tubules, the areas that can make sperm, are more normal versus the other areas. And you can see schematically that there are a lot of cells in here. These are sperm-making cells, whereas these other tubules have almost no cells in them. And again, the goal of that sort of surgery is to find the spots that work best, even if the FSH is very high or the testicles are very small for an individual man. It doesn't necessarily affect the chance of success. Sperm quality does have some effects on pregnancy. We talked about before sperm number, motility, morphology, but how the sperm looks really does not reflect how normal genetically the sperm is. So particularly in the cases of unexplained infertility, sperm testing may provide more information, particularly looking at these tunnel or SCSA tests that look at the sperm DNA itself. And we're trying to find if there's significant numbers of damaged sperm, that is, sperm with damaged DNA within them, because that affects the success rates of a wide variety of different treatments. And it may also direct us to consider getting sperm that are less damaged or decreasing the amount of damage that's present. Indeed, if we look at couples who have failed multiple IVF cycles, we find that in up to half of those cases, there's a defined major problem with the sperm in terms of damage in the genetic material, the DNA, or abnormal numbers of chromosomes. Both of these conditions are at least theoretically treatable, and if the tests are not done, then the cause of failure may not be identified. So even in cases where there's IVF that's failed, evaluate and everything looks normal, evaluating the man may be worthwhile. So certainly there are conditions where men have been treated in the past, for example, with chemotherapy or radiation, or where undescended testicles were present, or other things we can identify that caused low sperm production. But in many cases, particularly those with the lowest levels of sperm production, genetic conditions may actually have caused the infertility problems for men. And our current tests, although they're useful, do not detect the problems for 80 to 85% of these men. We're learning that these genetic conditions can be very complex, but fortunately, science is moving very quickly, and the testing is rapidly evolving so that we can and will develop new tests to evaluate men. The genetic conditions are important because they're the likely cause for what we call Sertoli cell only. That's the condition where the areas that are supposed to be making sperm are actually lacking any of the cells that can make sperm. And it also likely explains a lot of the severe problems with low sperm production. We believe that understanding these genetic conditions is really critical to allowing us to treat these men, because if you have cells and they're not developing, surgery may not be the best approach to treating. If we have a medical therapy that allow you to make sperm, that's the best approach to take. But if you don't understand what the problem is, you can't determine what medication to use. So in Sertoli cell only, the cells to make sperm have typically been lost from the testicle. Treatment would have to involve at some level replacing those cells, and that's a type of stem cell therapy which we don't have at this point. And also, we would likely need to fix the genetic problem that caused the sperm cells to be lost to begin with. So we may actually have two different types of treatments that need to be provided in that pure Sertoli cell only type of situation. That's where people say, well, why don't you have a treatment for me? And the problem with that treatment is it really may require multiple parts. And that's part of what takes so long in developing it. Everybody asks, when is that treatment going to be available? Where's the progress being made? Well, fortunately, progress is being made in a number of different centers. There are stem cell studies that are being done at nearly every university throughout the world. Fortunately, we have just recently gotten some grant funding from the National Institutes of Health to Cornell to both help us to understand better how those stem cells are supposed to function within the testicle, and also to help evaluate how you can generate those stem cells. But it is like building a spaceship. You need many different things to come together to make that work. You don't just need fuel to make it work, you need the external structures. You need the computers within it. You need a wide variety of different pieces of information that we still need to learn to be able to fix these types of problems, because it really involves creating cells to function within the testicle. Fortunately, again, at Cornell, we're very happy that we're going to be able to recruit more stem cell scientists. This is something Dr. Rosenwax and myself, the entire IVF teams and male reproductive teams are working on together, so we can accelerate this process along. And the type of testing that is being done is occurring at exponentially faster rates. Unfortunately, the cost to do these sort of tests and to do this sort of research is moving very rapidly. Up until very recently, it could cost us $100,000 to test one single gene for an individual man and to evaluate all components of that gene, and it could take us up to a year in the lab for that to occur. Now, you can screen the entire human genome, every gene, and there's tens of thousands, hundreds of thousands within other areas of the body, but several thousand within the testicle alone that function. And you can do that genetic testing for $10,000 within weeks. By next year, it'll probably be $1,000 or $2,000 within weeks. The next step that we'll need after that is to move and analyze the information that's created from it, because the information that's created from that could fill a stack of pieces of paper that fill a quarter of this room. So analyzing this information, the scientific background behind it is moving very quickly. It's becoming more and more feasible, but it will still be a while before we can identify the genetic problems and translate that into treatment. In summary, I think we've covered a little bit of how we evaluate for the cause of infertility, both from a basic standpoint and then more advanced treatments with genetics. Talked a little bit about some of the treatment options, which usually are based on the cause of infertility for the man. But treatment options exist even if there are no sperm that are present in the ejaculate. They always have to consider the female partner because this is a combined treatment together. And certainly novel treatments are being developed, but will likely require years or perhaps many years or decades to come along because they require a wide variety of different discoveries. So I'd like to thank Rabbi Flom, Rabbi Rosen for the opportunity to speak, and everyone for being here. Thank you.
Thank you, Dr. Schlegel. I just want to remind everybody that we're going to be going up to the classes now, and everyone can go to the classes that we picked so there's no mix-ups with what's going on. Also, whoever doesn't have padded papers in the back by the exhibitors, there's padded paper, and also there's in the back, so whoever didn't take an extra bag should take a bag inside the bag, there's padded paper to write down any questions and any notes. Also, it would be appreciated if everyone could visit at their convenience, the exhibitors in the back, to see what the centers have and what the centers can offer for that treatment. Thank you again, everybody. Thank you.
So as much as you know, it's not a, you know, that's the, I feel like the best part about it. But at some level, conceptually similar to what attracted me. I don't know.